Hello, my name's Ken Kinter. I'm an assistant professor at Rutgers University. The purpose of today's video is to provide an introduction to substance-related addictive disorders. And as usual, my contact information is on this title slide. Before we get rolling, I want to give some credit where credit is due. The project I work for is called the State Hospital Psychiatric Rehabilitation Initiative. Basically, it is a project whose mission it is to improve the quality of care and the working conditions at New Jersey state psychiatric hospitals. That mission would not be possible without the generous financial and other types of support from the New Jersey Department of Health. So we thank them for that, which makes our work possible. So addiction is way too big a topic to cover in just one small video. But this is what we're going to be taking on today. And we're going to stick pretty close to the diagnostic manual's interpretation of addiction. We'll talk about that as well. So we're going to talk about the different types of addiction according to the DSM-5. We're going to talk about some of the theories of addiction, talk about some of the treatment options that are out there, very brief overview of that. And we're also going to talk a bit about the relationship between trauma, mental illness, and addictions. There may be other videos coming in the series about things like 12-step programs and other specifics about treatment, but this is just meant to be a basic overview. So here's your definition right out of the DSM. Cognitive, behavioral, and physiological symptoms indicating that a person is still using despite the consequences to them. This is a good definition. It does not cover the social and spiritual aspects of addiction and the damage specifically that addiction does to those relationships. So that's a problem. Another problem is that the way the DSM looks at addiction now is it really refers to, you're not going to hear me too often using the term substance abuse. I prefer the term addiction because I believe the term substance abuse leaves out all of these other types of addictions, for example, sex, exercise, shopping, compulsive eating, et cetera, et cetera, et cetera. The other piece of this is that it is a pattern of behavior. So it's not something that just happens. Actually, my favorite definition of addiction is from a substance abuse counselor who said, is it hurting you and are you still doing it? If the answer to both those questions is yes, then you may have at least a mild addiction on your hands. So how the DSM looks at it now is they look at this list of symptoms and how many of these symptoms that the person actually meets determines their criteria. So some of these are very straightforward. Person uses more than they intend to. They've tried to stop before and they've failed. Their life basically becomes all about obtaining, using, and then recovering from the use, having cravings, starting to fail to fulfill life obligations and life roles due to the use, the continued use, as we just said, despite these worsening problems, the proverbial downward spiral, giving up activities due to use. The addiction is more important than other aspects of their life. Self-endangering situations. So a person is going to put themselves in a great deal of difficulty to obtain this. You think about the person that drives into a really terrible neighborhood to buy drugs in the middle of the night, or using something that you've gotten from someone somewhere. You don't even know what you're taking at a certain point. Continued use despite the physical and psychological problems. And then a couple really important hallmarks of these, we'll talk a little bit more about these, are tolerance and withdrawal. Tolerance is that whole process where it takes more and more of the substance to get the same result. And then also the withdrawals, which is the physical symptoms that come along with your body becomes so used to having this substance in its system that it doesn't know how to operate without it. And so that becomes a period of physical and psychological crisis for the body. So as I mentioned before, the way we talk about addiction has changed from the DSM-4-TR, the previous diagnostic manual, and then the current version of the diagnostic manual, the DSM-5. The old version, they divided everything up into abuse and dependence. The abuse was the preliminary or first stage or less severe stage, and it was where people were using something, because the idea is just because somebody uses something doesn't necessarily mean it's abuse. It's when these other things start to come into play. So somebody who has a glass or two of wine at dinner may not be an addiction. They're using, but it's not necessarily abuse. But if the person is drinking wine and then they don't go pick up their kids at school, or decide not to do something that they were going to do, and they start to reduce their involvement in other aspects of their life, that's when we talk about it. Hazardous behavior, we mentioned, legal problems, DWI being probably a classic, or getting busted for possession. And then interpersonal conflict. Before the person acknowledges that there's a problem, the people around them notice it's a problem, and then there's a conflict. We also have dependence. Here comes that tolerance and withdrawal again. The person that can drink more and more or use more and more without having that same effect. Withdrawal, again, these can be physical or psychological. It's that physical or psychological needing of that thing. It's not even a desire anymore. It's a need. I need this thing to get through a day. It doesn't even make me feel good. Just sort of makes me functional. And then at this point, role reduction leads to role abandonment. This is where a person just starts giving up on aspects of their life because they don't have room for those other things with the addiction. And of course, eventually it becomes just the addiction and them. And that's a bad place to be. So that's how it used to be done. That's sort of the old lingo that you still hear around, but that's not how it works now. Now, the symptoms that we were talking about before, and I'm going to click back to them. So you see here on the right side, 2 to 3 is mild, 4 to 5 is moderate, 6 or more are severe. And that's of these 11 categories. So if you have someone that fits 2 to 3, 3 to 4, or more of these symptoms, that's how the diagnosis is made. Now, there are different types of substance abuse disorders. And again, we're not talking about abuse and dependence anymore. You have intoxication, which is when someone's under the active influence of a thing. Withdrawal, I think we've talked about a few times already. There are other substance-induced disorders, and these may vary based on the effect of the drug. For example, caffeine can have an impact on someone's sleep. With something like LSD, you might have a persisting psychosis that happens after that. So each of these psychoactive substances can cause other things to happen. People use cocaine a lot. They can become very depressed afterwards. So each drug kind of has its own. The other term we need to get familiar with is remission. And the way it's described here is that if someone is free from a substance for 3 to 12 months, that's referred to as early remission. If it's over 12 months, that's a sustained remission. And then the other sort of corollary is, was that period of remission in a controlled environment where they didn't have free access to that? For example, I work in a psychiatric hospital. So if someone was using heroin, then they were admitted to the hospital. They were in the hospital for 9 months. You both could and might not consider them clean because of a theoretical lack of access. So you would put that little asterisk on there. Okay, they're clean 9 months, but they've been in a facility for 9 months. When they get out on the street again, get back out on the real world, then we'll see how they do. But at the same time, I might give that person credit, say, look, you can live without it. You've lived without it for 9 months already. So here are some of the other substance-induced disorders that we were just talking about. Different substances can bring on mood disorders, psychotic disorders, anxiety disorders. You see the list right here, and then there's one that's very specific to LSD. So it gets complicated. As we talked about, there's going to be this interaction between substance abuse and mental illness. We'll get into a little more detail as we go. The classes, as the DSM currently recognizes them, these are the classes. However, there's always new ones coming down the pipe. There's all these new designer drugs, and there's, I'm sure when the DSM-4TR came out, there weren't bath salts and things like that going on. So here are your major ones: alcohol, caffeine, cannabis, the hallucinogens, including PCP and LSD, inhalants, opioids, which, OxyContin is currently a significant one of those, and all of the, that group. Sedative, hypnotics, anxiolytics, that's your Xanaxes, your Valiums, things like that. Stimulants, including cocaine and methamphetamine. You have tobacco, and then there's other and unknown, because there's always something new coming down the pipe. And of course, as we've noticed, the DSM doesn't really care if something's legal or not. It doesn't directly impact whether something is a drug of abuse or not. Of course, if the drug is illegal, then that opens you up for so much more legal difficulty. And in the case of cannabis, the legal status is in quite a stage of transition now, but that's not really of primary concern. So I came into the field about 30 years ago. And one of the things that we used to fight about all the time was which came first? Did someone have a mental illness and then they started the addiction on top of that? Or did the addiction come from the mental illness? And it's a simple question, but it's a simple question that has a complicated answer. So, as we've already said, if someone uses a lot of substances, that can cause subsequent mental illness, mood disorder, or psychotic disorder, something along those lines. However, the common opinion that I've seen in the research is that usually the symptoms of the mental illness start to develop first, and the addiction is an attempt to medicate those. So that's kind of how that works. We'll talk a little bit more about that going forward. So as far as the prevalence and how common these things are, and I think all of these, I don't want to disparage the literature, but I think all of these are numbers are low. They're low to my experience and low to where I've worked. And it's a challenge to capture these numbers accurately. So I think the research that's been done, and it's cited in the references, I don't think it's a bad job. I just think it's a very difficult task. So 7.7 million Americans have the diagnosis. Out of the 21 million people in the US with a diagnosis of addiction, 37.9 are also diagnosed with a mental illness. So about 40% of people with an addictive diagnosis have a diagnosis of a mental illness along with. Out of the 42 million people in the US with a diagnosis of a mental illness, 18% are also diagnosed with an addiction. So that speaks to the overlap between these two things. It's not causation, it's more of the correlation aspect of it. I will also tell you that in the research I've done in the state psychiatric hospital where I work, 70% of the people coming in the hospital have an addiction diagnosis in addition to having a mental health diagnosis. So as it gets more severe, there might be a higher prevalence the more severely ill the person is. There's a lot of work that can be done on that one. So how we look at this is through the stress vulnerability model. And stress vulnerability model means that these things have a biological orientation to them, a genetic orientation to them, and then there's environmental influences as well. So you may have be talking about someone who has a lot of addiction in their family. And there has been some research done that indicates that there is a biological predetermination toward addiction. But not everybody who has that biological predetermination actually manifests that addiction. So what causes that addiction to happen? And there's a few different things. This is where the role of trauma comes in. The ACE study has clearly shown the more trauma someone has, the higher risk that they are to developing an addiction. If a person's in an environment where they have earlier access, so that they're using a substance when their brain is in an earlier stage of development, the likelihood of addiction is much higher. So you've got the biological piece and you've got this environmental piece that can come and trigger that off. I love this drawing, and I found this a while ago. My own personal view of how I look at mental illness and trauma and addictions is comprised of this. So you have a volcano where you have all of this red hot magma coming up, and to me that is the trauma piece coming up. And what happens is, and it manifests, you see all the smoke and all this disturbance coming up. Well, here comes the helicopter with this plug for the smoke. And to me, this is what the addiction does. It puts a cap right on top of that. So it keeps all that stuff in. Unfortunately, what would happen if you put a big cap on top of a volcano? Well, this has happened before. And what happens is the sides of the volcano blow out. It becomes a much more dangerous explosion. Instead of going straight up in the air, it goes out in all directions. And we've got a cat down here and a duck down here and a car running away and a small house and ants and worms. And they're going to have a really bad go of it. So to my view of it, very often addiction is an attempt to medicate the mental illness symptoms that come from the trauma. This is a little bit more scientific of a way of looking at it rather than the volcano picture, but I think the volcano picture is a lot better. So at the core, you have this trauma aspect here, then you have the symptoms of the mental illness that come from that, and then the addiction becomes a method of trying to cope with that. So the bad news of that is, as soon as you try to get this person clean and sober, these symptoms come out again. So, okay, great, you're clean and sober. The bad news is now that you're having mood swings, panic attacks, depression, hearing voices, whatever. Great. So now you get through that level of the onion, and you get through the mental illness, and then you go back to the original trauma. So as I tell people that I work with who are dealing with addictions, when they get clean and sober, they think the job is over. And I said, the bad news is it's just started, but it's still progress. So as we were talking about before, if the trauma is the original wound, the mental illness and the addiction are these surrounding layers around it that have to be dealt with first so that you can get right back to the wound. A compelling thought that I'd seen in putting this material together was addiction is a grief process interrupted. So what is the person grieving? What did they lose? What died? What was it that happened? And again, I think it speaks back to that original trauma. They didn't have a chance to resolve that original thing, and now all this other stuff is piled up on top. And as we talked about in some of the other presentations, at the age that an addiction begins, that person's social growth and development begins to slow. So there's lots of people out there in their 30s and 40s, but they may have kind of a teenage perspective on things because that's when the addiction began. So the other challenge about addictions is you solve one method of addiction or one type of addiction, and unless something good or healthy goes in the place where that addiction was, either the old addiction jumps back in there again, or a person has cross addiction. The majority of the people that I work with and see now are not addicted to one thing. They're what they call polyaddicts, which means you just go from one to the next to the next. And if you look at their life, there's this sort of strand of different types of emerging addictions going on over time. Now, that's not to say that person has an addictive personality. That has largely been disproved in the literature. It's really not that. It's just continuing attempts to medicate this wound. So the example, and this is a real example, is a person who's working over 80 hours a week. His blood pressure is going up. He's very stressed. So his therapist told him to get a hobby. So he decided he liked wine. So he started collecting wines, and started collecting wines rather compulsively, by the way, which was also interesting. And then later on, of course, developed alcoholism. So his respite became his, his next addiction. And then the other example, the person who is a food addict, became morbidly obese, has bariatric surgery, becomes thin, and then begins smoking because that addictive energy has to go somewhere. And this is probably my favorite graphic about this. If any of you are familiar with the Shore and ever played a great game called Whack-A-Mole, this is how Whack-A-Mole works. So we got the little hammer there, and we're going to whack alcohol. And unfortunately, once that head goes under again, it's going to pop up somewhere else. It might pop up under gambling, may pop up under cocaine. So here's our problem. If you just keep hitting those moles down, but you don't attend to what's going on underneath it, it's just going to pop up again somewhere else, and it'll pop up as alcohol again at some point down the road as well. So some of the new aspects of addiction going on is, one is sort of the failure of the gateway drug. Back in the day, there was this kind of clear process where you smoked a cigarette, you drank a little, you tried pot, and you worked your way from these sort of legal, more present, and maybe less immediately dangerous drugs. A gateway drug now is just the first one you find. There are kids that have access to OxyContin and various drugs through their prescription drugs through their family members. So it doesn't really work that way anymore, where people just have access to everything. So it's whatever gate you take. There's also some reason to believe that addictions are starting younger as well. That also makes it more challenging and more difficult. We mentioned about the polyaddicted. It's street drug use is taking a back seat to prescription drug abuse. In fact, some people are backing into street drug use. For example, the person who starts with OxyContin, and then as they move down that addictive cycle and they lose their job, lose their benefits, lose money, then they end up resorting to heroin. So they've backed into street drug use. The versions of drugs that we're using are becoming much more powerful. So their psychoactive effects are much more dominant. I've seen I think I grew up on marijuana that had a 3 to 4% THC content, and now it's upwards of 36%. So it isn't your grandma and grandpa's weed anymore that's out there. The purity is much higher. The dangerousness of these drugs, if you've seen the numerous addiction deaths, it doesn't take that much to do it because of how powerful these drugs are. And then the other piece is the role of the internet in process addiction, sex addiction, gambling addiction, shopping. You can absolutely devastate your life with an addiction without ever leaving your home, just with the use of your phone or your computer. So we move on to treatment, and the traditional modes of treatment have been inpatient or outpatient. Inpatient is divided, and these, I want to point this out because these terms are sometimes used interchangeably and they're not. Detox and rehab. Detox is a medical procedure of the drug physically being removed from your system. It is not a recovery process. So I just wanted to point that part out. When someone gets to rehab, that's where you actually look at, okay, why are you using? How can you stay clean? The detox process is just waiting it out and then whatever pharmaceutical assistance to help that person physically get the drug out of their body. There's also sometimes after inpatient treatment, or in lieu of it, residential treatment. Because of course, part of the challenge is how do you get that person out of the environment where they use? So there are halfway houses, quarter-way houses, lots of different options there. Outpatient treatment, you've got traditional individual and group therapy, partial care programs that are during the day, and then something else called methadone treatment, which we'll talk about that a little bit in more detail. Methadone treatment has changed over the years. Initially, when it was really kind of set up for people, it became very popular during the 70s when people were coming back from Vietnam and they were addicted to heroin. And the idea was that you substitute it. You give a legal substitute and a minimal amount of that just to keep that person going. Over the years, people have fallen out of love with that model. And then it's become a matter of just stepping someone down. It's a staircase down until that person can function with zero again. The track record in it is not spectacular because people use on top of it. It's a very difficult process to go through. And I'm also a little critical of the take the pill for your addiction model. It doesn't address the underlying thing. It just tries to get you to change how much of a drug you function on. And here's some more of the pharmaceutical aspects of it. Antabuse, it's a medication that you take that makes you violently ill if you consume alcohol. And then you have Suboxone, buprenorphine, and it's the idea of it's a drug that you take, a medication that you take so that if you use on top of it, you don't get the high. So if you take your pill, you don't get the high, you're less likely to use. Again, if we go back to our whack-a-mole model, we're not treating the cause, we're treating the symptom. So I'm not sure how great these outcomes are because you're not addressing what's really going on. Forget addressing the trauma or the mental illness underlying. The 12 steps, again, we may do another presentation that covers this in a little more detail. I don't want to get too into that. There's a couple million people worldwide that are involved in these 12-step programs, these sort of spiritually based programs. They're running in churches in your town, and there's an AA and an NA and OA and every type of 12-step organization you can imagine. And the idea is people just get together, talk about their problems. There's a big book. There's all sorts of stuff around that. We'll get that into other detail about that. But it's very spiritually based. And that is the benefit for a lot of people. And then for other people, that really doesn't work. There's something else called smart recovery, which is a much more cognitive behavioral approach. It works in a similar method to AA, but it doesn't have all of that higher power spiritual aspect to it. And all of the resources are available on that website. You can get a look at the materials, this 4-point program that I've described. All their materials are available online. And they have meetings similar to the 12 steps. So when recovery is working, my theory always has been if you have to drug screen the person, you're not doing your homework, because the greater part of addiction to me isn't the use, it's all that other stuff. It's a matter of that person being honest, being simple, their life being simple and uncomplicated, nothing to hide. When recovery is working, things just work. It's very smooth and there's not any stories about anything. The person's taking better care of themselves. They're more accountable, more responsible. Recovery is really a transformative process that affects that person's whole life. When it isn't working, that's when things get complicated. My running joke is that someone who has an active addiction can't answer a yes or no question with a yes or no. It's, well, you see, it's like this, and then buckle your seatbelt because you're going to go for a ride. Someone's attendance isn't good. They don't make it to places on time. They cycle through blaming other people for their problems, being a rescuer, and then having to be rescued. Gaslighting, we could talk a lot about in greater detail. We'll talk about this with some of the resources in the end. Gaslighting is where they turn everything back on you. The addict kind of blames you for everything to put you on the defensiveness. There's moments where they're okay, and then there's moments where they're in complete free fall. They don't say that they need help. There's just no easy answers to anything. It's very hard to be an honest addict. Either you end up being a recovering honest addict, or either the honesty or the addiction has to go. Those two don't sit too well together. So working with people with addictions, challenging, because a lot of people with addictions need to create all sorts of chaos around them so that they can keep using. That's part of that gaslighting business. So here are a couple assumptions coming in. Now, if you're working with a group of people, you work with people with addictions, you are a team, and that team has limitations. The best thing you can do is for the team to be all on the same page, because the active addict lives in the chaos between when people are split. You can't make a person get better. That means it's not your credit when they succeed, and it's not your fault when they relapse. They are ultimately the arbiter of their life. Addicts are masters at dividing staff. As I mentioned before, you create chaos around you, which perpetuates the addictions. They play on our own wounds. So we've already discussed people with addictions have a greater, may have a history of having more experience with trauma. They may also be playing on your trauma as well. You know, if you work at providing care, you've got your own trauma, you've got your own background, and they will find that stuff. And most of us have addictions, you know, in our families as well. Consultation is key. Do not travel alone. If there's something that you're not sure about, consult somebody about it. So we all have our own blind spots. You represent yourself and an agency. Not always will they agree. Your agency may have rules regarding people with addictions that you may not be okay with. And then you have a decision to make. You have to be true to yourself, but it's also really nice to have a job. And I'd love to be able to give you a more direct answer to that, but that's a battle you're going to have to fight personally. Your personal values and the values of your job should be in some sort of alignment. Addicts have no boundaries. The addiction is seen to that. People with an addiction are about their addiction, and they will sell themselves out and sell everybody else out around them to fulfill that addiction. So it's nothing personal, has nothing to do with you. My wife, who's a fantastic clinician, does not enjoy working with people with addictions. And she said, I don't like working with them because they lie to you. And my answer to that was, they're not lying to you. They are lying to themselves. You're just in the room when it happens. Don't take it personally. They're lying to themselves. So some of the other resources to help out with this, I would definitely recommend taking a look at so the 12-step big books. The AA is sort of the classic, but there's all sorts of other ones to get an idea of how that 12-step things work. I would definitely encourage you catch an open AA or NA meeting, just so you can go in and see how it works, both so that people with addictions that you work with can't tell you stories about how that part works. You know it for yourself, speak the language. There's some other great books about this: Betrayal Bond by Patrick Carnes, Gentle Path to the 12 Steps, Codependent No More and Beyond Codependency. We didn't even get into codependency, but that's an important part of working with addictions as well. And of course, getting our own help, because anything that we do with these clients, they know our buttons, they will find them, and you'll keep having your buttons hit until that work is done. So some of the summaries of what we've talked about: there are many types of addictive disorders, more in common than separate. To be honest with you, there's actually a school of thought saying that there's no such thing as a cocaine addict or an alcoholic. There's just an addict, because most people cycle from one to another. There's a big push in that direction to sort of push all of those disparate addiction treatments together. There are substance and process addictions, but many process addictions aren't fully recognized by the DSM-5. Currently, only gambling is. More types of addiction are emerging all the time due to the emergence of new drugs and the role of the internet, and that's not going anywhere anytime soon. I think Chris Rock, the comedian, makes a great joke. If every drug of abuse disappeared off the planet, we would immediately start inventing new ones tomorrow. He has a very funny piece about that. Addiction is thought to have biological etiology, but trauma also plays a role. The environment also plays a role as well. Treatment consists of outpatient programs, inpatient programs, residential maintenance programs, and then, of course, we were talking about the smart recovery and the 12-step programs as well. And addiction and mental illness often travel together and can aggravate each other. We've nicknamed double trouble, and they're actually double trouble meetings as well. The idea is, hypothetically speaking, if someone has bipolar disorder and they are addicted to cocaine, when their bipolar symptoms are unstable, that may prompt them to use cocaine. And of course, if they're using cocaine, then that creates all sort of havoc with their bipolar disorder. So it's really two burdens for the price of one. You can't just stabilize one without stabilizing the other. In New Jersey, we discussed something called no wrong door, because back in the day, what would happen is, we'll take this hypothetical person, John, who has bipolar disorder and he's addicted to cocaine. He would go to the mental health center, and the mental health center would say, well, John, you got to get clean from the cocaine and then come back here and we'll treat your bipolar disorder. So go to this treatment center. So he would go to the treatment center, and the substance abuse treatment center, and they would say to him, well, John, you got to get your bipolar disorder straight, and then we'll take care of your cocaine addiction. And then John, of course, would fall out of treatment at that point. So now the idea of no wrong door, we have to take care of both sides when they come to us. So some of the resources, the books that I was just talking about are right here, the DSM. This is the article on the prevalence of mental illness and substance abuse together. These were some very helpful websites that I used in it as putting this material together. And if I were going to give you guys a homework assignment, which I'm famous for doing, there's a skit called The Wrong Number Skit by Carol Burnett. You can find it on YouTube. If you want to see what gaslighting is, that 7-minute video will let you know what it is. There's also a classic movie called Gaslight. I haven't seen it, but it's kind of where the idea of the gaslighting concept came from. So you might want to check that out as well. I think it's from the 40s. So it was nice talking to you as always. Hope to see you again at some point. And also, if you have any suggestions for topics, don't hesitate to reach out. We're always looking for new material to make up. So I hope this finds you well and healthy, and catch you again soon.